It will go on till another 1 hour or more.
Progress. I think Dr. Shubha Gudi madam has also joined. Good afternoon, ma'am.
Good afternoon. Good afternoon. Hello, Madhuri. Good afternoon.
Yeah. So, Pradnya, why don't you start?
Yes, ma'am. Shall we start, Madhuri, ma'am?
Yes.
Okay. Maria, I can start, no? Maria?
Yes, ma'am.
Okay. So good afternoon, everyone. I welcome you to the FOGSI JOGI web series, Clinical Pearls of JOGI, episode 5. We've had 4 really wonderful episodes in the last 4 months where all our award-winning papers have been presented. I now call upon our EIC, Dr. Madhuri Patel, ma'am, who will welcome all of us and brief us about the Clinical Pearls of JOGI webinar series. Over to you, Dr. Madhuri Patel, ma'am.
Thank you, Pragna. Before that, can we have a Saraswati Vandana?
Om Saraswati Namo Namah Ma Saraswati Namo Namah Vidyadayani Namo Namah Hansavahini Namo Namah Om Saraswati Namo Namah Ma Saraswati Namo Namah Vidyadayani Namo Namah Hansavahini Namo Namah
Thank you. Thank you, Dr. Pragna. Respected our President, Dr. Jaideep Chan, who is just next to me, sitting in Delhi and having a meeting. And so he's unable to join. So he has said apology. But he sent me to join this meeting. So very nice of him. And today's our guest of honor, Dr. Alka Kuplani Madam, my dear friend. We have been working since last 2 decades. I was joint secretary when she was vice president to Dr. C.N. Purandare. And she's a great academician and she is a great orator, great clinician. And, overall, above all, she is a great, human being. And what to say about our another guest of honor, Dr. Rishma Pai. We are friends since so many years, maybe more than 3 decades. And she's also the great academician, great orator. And, when both of them, presidential year, I was there as an office bearer administrative, and I really enjoyed working with them. And they have done lots for the women's health. So then our editor emeritus, my mentor, Professor C.N. Purandare sir, Professor Dr. Adi Dastur, Dr. Suvarna Khadilkar, and Dr. Geeta Balsarkar. And of course, our past president, Dr. Prakash Trivedi, who is going to talk today. So I'll be, we are really honored that, sir, you are there and, to guide us. And, you are going to talk how you started this. And it will be inspiration to our juniors also. Today's chairperson, Dr. Anahita Chavan, our assistant editor, very, very efficiently doing all the work in the journal. And I'm really thankful to her. The national corresponding editor, Dr. Subhash Chandra Bishwas, and Dr. Shobha Gudi. Those 3 are chairperson for today's episode. And I am sure they will do the excellent, good work. Then our editorial team, Dr. Sujata Dalvi, Dr. Arun Nayak, Dr. Anahita Chavan, Dr. Ashwini Bhalerao Gandhi, Dr. Pragna Changade. Pragna Changade is also, doing a great work. She and my Sunil and another Pragna, they are doing such a fantastic work. So the clinical pulse of Jogi is happening, going very well. Then my national corresponding editor, Dr. Krishnendu Gupta, Dr. Lakshmi Shikande, Sushil Chawla, Radhika, Dr. Kiran Maish, Dr. Shobha Gudi, Dr. Deepti, Dr. Mala Srivastav, Dr. Alka Pandey, Dr. Madhva Prasad, Dr. Krishna Kumari, Dr. Sampat Kumari, Dr. Ashok Kumar, Dr. Ramni Devi, Dr. Subhash Chandra Bishwa, Dr. Nidhi Gupta, and all my dear reviewers and all my dear friends. Very good evening to all of you. It is with great pleasure and anticipation I welcome all of you for today's fifth episode of Clinical Pulse of Yogi. This was conceptualized when I was in America with my daughter, and my son-in-law is also the one of the editorial board member of Elsewhere Journal. And we were just discussing, and he said, "Then why don't you start, mommy? This program, because it is everywhere. We all speakers are there, but these authors, they don't get chance. Of course, we publish there, in the journal. It is a wider reach. But when they present their research work, hardly few people are there in the hall. So we thought, okay, why not to give them this platform so they can present their work, and we can actually know that what are the things they have gone through. We get the opportunity to learn from the authors, so we can have a discussion with them. And any one of them want to do this program, they can really repeat that thing, that program, or whatever research they can take from them, the junior one. And this is another thing we feel, that this award-winning paper we are presenting since last 4 episodes, they were very, very interactive, and they were very much well, conceived by everybody, and they all are happy. And this is today's the fifth program. And I really welcome Dr. Prakash Trivedi for his talk. He had got in 22 the prize winning paper in senior category, and he's going to talk on laparoscopy in bag morcellation compared with conventional morcellation of myomas and uterus with myomas. Then the junior category, we are having second prize winner, Dr. Nikita Kumari, and she's going to talk on effect of a locally tailored clinical pathway tool on VPEG outcomes in a private hospital in India. So, I'm really happy. I've gone through both the papers. They're excellent, and they will be really helpful in our clinical practice. So I'm very, very confident that this is really giving a great result to our budding, gynecologists and obstetricians who are motivated to do the present the papers. One more thing I would like to say, that our Jogi is read by many, many people. It is internationally known also, and they like to subscribe our journal. So our journal is also doing very great job. And with this, I invite our MOC to take over from this.
So thank you so much, Dr. Madhuri Patel, madam. So we have had 4 successful episodes of Clinical Pulse of Yogi, and we have already presented all the good and prize-winning papers of 2023, and now we have reached the year 2022, and there are many more papers which need to be presented. Let me thank Dr. Madhuri Patel, madam, for giving opportunity to all the authors, because authors always feel that, they keep on wondering, I publish, but who reads my work? And, whenever we read an article, we have so many questions in our mind. We want to interact with the authors. And this is a beautiful platform in which we can ask certain questions to the authors. Otherwise, we have no access to these authors. So thank you so much, madam. Let me introduce our chief guest for today. Our chief guest for today is Dr. Jaideep Tang, sir. He is the president of FOGSI. He is the chair of IGDA committee OFOG. He has led various projects in FOGSI. He has been the secretary general of FOGSI. He has been awarded the FRCOG honoria causa by the RCOG. He has been the past president of MOGS. Sir is a consultant at Ashwini Maternity and Surgical Hospital, Ghatkopar. He has been the past deputy secretary of AOFOG, immediate past chair of FIGO Committee for Safe Abortion, past chair publication and newsletter AOFOG. And he has drafted so many proposals for FIGO, which has resulted in a grant of $13 million in Africa as well as South America. And he's the technical lead for the project. He has supported FOGSI, led FOGSI in so many bills like the cesarean rate, hysterectomy rates, ART bill, surrogacy bill, and the list is endless. Sir is busy in a meeting in Delhi, so he has conveyed his apologies. Let me introduce our guest of honor for today. Our first guest of honor is Dr. Alka Kriplani, madam. She is the director and head Department of Gynecology and Obstetrics and ART at Paras Hospitals, Gurugram. She's an ex-professor at AIMS, New Delhi. She has been the president of FOGSI, president of Gynecological Endocrine Society of India, DGES, which is the Delhi Gynecological Endoscopic Society, Association of Obstetricians and Gynecology of Delhi. She is the editor of Asian Journal of Obstetrics and Gynecology, and she's also on the editorial board for 9 journals, and she's the co-chair of FIGO Menstrual Disorder Committee. She has several awards, which include the Padma Shri, Dr. B.C. Roy, the Honorary FRCOG, and several other awards. Has Madam joined? I think so. She will be joining in some time. In the meantime, let me introduce our next guest of honor, Dr. Rishma Dhillan Pai. We all know Madam. She is the treasurer of International Federation of Fertility Societies. She's been appointed in the Menstrual Disorders Committee of the International Federation of Obstetrics and Gynecology, popularly known as the FIGO, in 2023. She has been the former president of FOGSI, former president of ESAR, former president of IAG, and former president of MOGS. She has received the honorary FRCOG. She is a member of the FIGO Committee on Menstrual Disorders. She has received the FIGO Women's Award 2023 at Paris, and also received the Lifetime Achievement Award by the Indian Society for Reproduction and Fertility. She has received the Health Mentor Award, the Lokmat Group by Health Minister, Award by Governor of Maharashtra, and Dr. B.N. Purandare Award. I request Madam to please say a few inspirational words for us.
Thank you. Thank you. Good evening to all of you. And congratulations on the huge success of this ongoing CME. Truly remarkable, and some of the points that you stated earlier is really true, that the journal is very, very prestigious, and really full credit to all of you behind it. Dr. Madhuri, I don't know how much work she does as Secretary General and as editor. It is just unbelievable. I think she has a little corner in the office where she curls up and sleeps in the night also. She spends so much time there. But truly remarkable. Our leadership of Dr. Jaideep Tank, all of us know he's doing amazing work at another level, truly, way beyond what most people can even reach. And of course, there's a whole super strong team behind with Anayata. I know how hardworking and amazing she is at this job. Dr. Subhash, Dr. Shobha Gudi, and all the young Pradnyas. So much confusion there must be between Pradnya Supe and Pradnya Changre. And of course, Sunil. So all of you are doing an excellent job, and congratulations for that. And more so that you're bringing the journal to life. And that, I think, is amazing, because it's a stagnant document, if you will. And having the opportunity to really meet with the writers, their thoughts in their mind, what really went into the need to put that research into place, and what they finally concluded. I think it's amazing that you can actually have interactive session with all the writers. And I think that was a really unique idea, Madhuri, and an amazing one. And really, I feel like we discussed before the CME starting that it's like a live journal, right? So you can't bring a journal to life. You can have online journals, but this is amazing that when you interact, maybe in some of your issues, you can even have some videos being shown if necessary, so that, you can bring to life even more the articles. And I truly believe that, for really good ideas and true innovation, you need human interaction. You even need conflict. You need argument. You need debate. And that, I think, is what can happen on this platform. So thank you so much for bringing this real live interaction. Truly, all of us and the ones who are logging in today are privileged to have Dr. Trivedi on the other side. And a very interesting article, which I had to read twice to understand what it is, the VBAC story. So I think it will be very diverse, two interesting, different and wonderful topics. All the best to you. I hope it's very, very successful. I'm sure it will be like your previous CMEs. And let's hope we have many, many more. Thank you for acknowledging the winners. I think the more platforms you give them, the more accolades to them, the better it is, because somebody who can win these presentations and journal articles and this truly are super achievers. So congrats. Thank you for inviting me and giving me this honor. Thank you.
Thank you, Reshma. Thank you, Reshma, for accepting the invitation and joining, and giving your call of wisdom. That is very, very important to our juniors. Thank you very much.
Thank you.
Thank you so much, madam. You've always been an inspiration. Your presentations are always up to date, and we really look forward to learning so many things from you. So thank you. I now request Dr. Sunil to introduce the chairpersons for the session. And whenever Dr. Alka Kriplani madam joins, we will ask her to say a few words. Thank you.
Yeah.
Sunil?
Yeah. So respected seniors, faculty, and dear delegates, as Sir Edward Deming has said, without data, you are just another person with an opinion. So these are the research principles, what we believe in and what we do at JOGI. I now invite the chairpersons for the today's session. It's my privilege to invite Dr. Anahita Chauhan, madam. She's senior obstetrician and gynecologist from Mumbai. She is immediate past president of Mumbai Obstetrics and Gynecological Society, where we had seen a dynamic year under her. She is assistant editor at JOGI, honorary consultant at Safi Elizabeth and many more hospitals in Mumbai. She has been former professor and unit head at St. GS Medical College. We welcome you, madam. Thank you. Next chairperson, Dr. Subhash Chandra Biswas, sir. He is senior obstetrician and gynecologist, working as HOD and at Department of Obstetrics and Gynecology, Institute of Postgraduate Medical Education and Research, Kolkata. He is past president of Bengal Obstetrics and Gynecological Society. He is our national corresponding editor at member of International Publications Committee, IUGA. He has been peer review for several journals, and he has been secretary to Board of Studies, West Bengal University of Health Sciences. Very active, and many committees he has led under JOGI. Thank you, sir, for joining. Next chairperson. So dear delegates and faculty, it's my proud privilege and it's a special day for me today. It's an opportunity for me to introduce my postgraduate teacher here, Dr. Shobha and Goody, madam. So I am very happy. So madam is senior obstetrician and gynecologist from Bangalore. She is very much active at Bangalore Society and FOGSI. Indeed, active figure and senior consultant at Bangalore. Practicing, she's at many hospitals in Bangalore and professor and HOD at St. Philomena's Hospital. She is past president of Bangalore Society of Obstetrics and Gynecology in 2018. She has been president, chairperson of Family Welfare Committee, FOGSI, 1921, secretary of Bangalore Menopause Society, assessor for Government of India Project Lakshata, board member of FAPI, has peer reviewer, and now she is selected as a national corresponding editor at JOGI with us. She's been part of many committees as well as done lots of work for FOGSI, recipient of many awards and publications. Thanks for joining, ma'am. We are very happy to have you. So I request chairpersons.
Thanks indeed, Sunil. Thank you very much.
Yeah, madam. So I request chairpersons to invite the speakers for today's program.
Thank you. Thank you very much. Thank you all.
Yes, sir.
Hello.
Yes, sir.
Yeah. Okay. Dr. Sunil,
Yes.
you have nicely presented and set the ball rolling. But it's our proud privilege to welcome Dr. Prakash Trivedi, all the stalwarts, starting from our Secretary General, then our FOGSI President, everyone has been introduced with the members present over here today. But I am very fortunate to introduce Professor Prakash Trivedi, my old friend. And Prakash, whenever he comes to Kolkata, he teaches me so many ways. So here to read his biodata is very difficult, but even then to highlight few, he is the gynecological endoscopist, urogynecologist, and ART consultant. He is director of Dr. Trivedi's Total Women's Healthcare Hospital and Akar IVF ICSI Center, Maharashtra University of Health Science, recognized doctoral fellowship training center for minimal access surgery in gynecology. And he is the pioneer of 3D 4K laparoscope, then hysteroscopy, urogynecological surgery, so many things. So I think better to listen from him rather than to just reading his biodata, particularly the work, the pioneer work on this field, that is the morcellation, because the debate is going on throughout the world, and few years back it's raised a real problem whether to use or not to use, and right at that moment Dr. Prakash has shown the path. So the platform is yours, sir, so you can present and we can learn from you. Thank you, Dr. Prakash.
Sure. Thank you very much, Dr. Jaideep Tank, our dynamic president, then Madhuri Patel, the ever dynamic secretary. Honestly, today I feel that I am sitting in an exam with so much stalwart. Alka Griplani, Reshma, Anaita Chavan. Shobha's name was very nicely told by the students. Shobha and Goody. And Goody. So basically, with so many experts, I'm actually feeling first time that I have an exam, you know, and I will try and do as much justice as possible. First of all, it's a great honor to be having an article in JOGI itself. Getting an award is another thing, and sharing today makes it real, the reach wide, and of course, this can be permanent material in JOGI itself. Now, everything starts with some controversy, and what happened is Amy Reed, an anesthesiologist, had a surgery for fibroids after delivering 6 children. And sometimes I worry why after 6 delivery, anybody needs morcellation. And then it was done by an expert surgeon, and it turned out to be uterine leiomyosarcoma. After 2014, she passed away in 2017. But in the meantime, husband of Amy Reed, a cardiothoracic surgeon, obviously America is full of law, legality, and he approached US FDA, he approached Wall Street, he approached White House, everything. And then they announced, initially it was almost like a ban. Though they always stated it is not a ban, because Dr. Subhash, you will be shocked that from 17th April 2014, almost people were wonderstruck. And it told that all this morcellation can lead to unexpected spread of cancer. What happens is, you know, the impact of FDA warning was that they found that because of FDA warning, people either in myomectomy or in hysterectomy stop doing morcellation, whether contained or uncontained. And actually, if you see, it led to problems, which is believed that 80% had open surgery. And of this, 55.1% had more problems than any morcellation. So without understanding, what happens is, when I had discussed with US FDA about different aspects during COVID, whether it was this fibroid, etc. and all, US FDA clearly told that we don't control practices in other country. But what happens is, anything goes in America or anything goes in UK, automatically it percolates everywhere. And there are multiple reasons for people disbelieving in morcellation. I've been fortunate to do morcellation from 1994. and we have one of the largest number of fibroid through reference and otherwise. But I thought at that time, my thought was, what is common between leiomyosarcoma and fibroid? The only thing which is not common is there is no method by which you can diagnose leiomyosarcoma. So basically, US FDA warning did more harm than benefits by increasing open surgery without understanding whether it is necessary or whether it will be beneficial for patient, and more patients are harmed. Even now, with limited group of people, they can raise a voice because law at many places is very strict. Fortunately, in India, I respect India more for our democracy. And I had discussion with the health department also. And it was very clearly informed to me that there is no such restrictions that we have in India. Now, there are many people, what they do is they do laparoscopic myomectomy, or for example, a large, and then that large specimen is removed by a mini lap incision. Now, this is not a mini lap incision. It's almost that you can do a laparotomy. So this lamb, once in a while you may need it, but as a routine to do laparoscopic excision of fibroid or hysterectomy and then removing the specimen by widening the mini lap incision, which is the 5th incision. In fact, this, if you see 1, 2, 3, 4, 5, this is one of the very popular laparoscopies from India, but these are the scars. Then umbilical hernia is another thing. These are another so many cases. So basically you have to remember that it added too much of problems, and unnecessarily people wanted to suddenly become more tech savvy to trying to remove 16 centimeter tumor to 3 centimeter. So all those small incision is never small. At the end of the day, you find it is at least 50% of a regular laparotomy. So there are many steps which one has to control in myomectomy. Vasopressin, myometrial incision, fibroid enucleation, closure of the myometrium, considering the rupture chances, which is published in meta-analysis on fibroid, that open ruptures were underreported. It was only when laparoscopy was done, there was more people who used to focus. So we always believed that if you are good in laparoscopic suturing, in fact, Charles Coe used to tell way back in 95, 97 in AAGL when we used to present, this surgery should be called as microsurgical laparoscopic myomectomy, because he told that all the principles which are to be followed, whether it is Trivedi or whether it is another excellent surgeon from India, they all have proved, and so none of this has concern to spillage. So one step which is in control with the operator is how you remove the specimen. Now we have to remember that a sarcoma doesn't take place only when it's a fast-growing tumor or a big tumor, because all of us know a sarcoma can be in 4 centimeter mass also. I started working on research on fibroid from almost strict research from 1992. And I was very sure that there is something they are missing. So in crisis, I always get excited. Not excited because I know, okay, we'll find out some solution. And then it so happened that we started working. Now what happens is, what are the common methods? People will do by widening or enlarging a port, transvaginal removal. It is like pulling an elephant from the tail. And pouch of Douglas or opening is a poor man's morcellator. So there are many people who used to try and remove large fibroids through pouch of Douglas. Of course, it's not possible in a nulliparous. It is not possible in unmarried female. And sometimes you also think it's a very simple method, but you have to think that I will make a very important declaration. I operated my wife who had a fibroid. I have operated my sister who had lipoma and fibroid. And my son has operated some close relative of his. So you have to understand as if it's your wife, your sister, your daughter, daughter-in-law, or any other person. So every person is important. The dissemination, whether it is reduced by all these methods, it cannot be alleviated. Enlarging the incision doesn't justify it as a minimal access. We call it as maximal access surgery rather than minimal access surgery. So I'll just show the technique and then go to the paper. So we introduce this contained bag morcellation. After we have separated the specimen, this is the stomach-shaped bag. So we fold this bag and introduce into that plastic trocar, which goes through the 10 millimeter port. You go in, the assistant holds the mouth of the bag, and the plastic trocar is taken out. As plastic trocar is taken out, you plus the assistant will pull, and we open the bag. After we have opened the bag, we put the specimen inside. It can be one, it can be multiple, very large statistics will come. And everywhere, even recently when I was in Verona for cadaveric dissection, they asked me to talk on direct uterine and contained bag morcellation. So what happens here, if you see, is the same morcellator, which is rotocut. There is sometimes people keep talking about power morcellation. Some companies, these are the uteruses, sometimes you have to remove. The beauty about uterus is once you have 3D camera or now we have 4K with ICG technology. As Sonala sir used to always tell, in cesarean, the round ligaments remains low. So our vessels are still below. So once you bypass with pneumoperitoneum, once you bypass the uterus, your vessels are very at the same place. You can easily access those vessels in certain cases. And this bag is then removed. Then the tail is now put into the umbilical trocar. And it has a small hole. We modified this and we made another hole closely. And then we go inside. So now you know that the mouth is outside, specimen is in the bag, and your tail is with you. And then on 14th May 2015, we did the first case, and next day we had a IAG and AAGL workshop, and they saw in-bag morcellation for the first time. So now once it is in, then you can either use a tenaculum, and this hood which is there on the top ideally allows you to take long strips. In fact, in Calcutta itself, Subhash must be remembering, once I was doing a morcellation, we removed a 58-inch strip. In fact, I had a video also. So you can use either this morcellator, but what happened is one company who became unpopular because of the mesh, and that morcellator was used in the American patient. So they stopped manufacturing power morcellation. They stopped manufacturing tapes. And all this was because there were strict guidelines. And see, this is the tissue blood, which otherwise spills. So in laparoscopic surgery, this is the amount of size of fibroid we have. The next thing, we remove the trocar and tie a knot and just pull from the mouth out, and the procedure is complete. Sometimes we have very big size uterus, And from the time of the ban, we are having innumerable patients from abroad because lots of places follow the same thing what America is following or what UK is following. And they realize that if they want to have a contained morcellation, or many people also thought that they want to save the uterus for fertility, then they started resorting to coming to India. A lot of people started coming to me and my colleague, even Alka Kriplani, who also does an in-bag morcellation. And the world is great. Once it gets published in every corner, currently I am evolving a research on fibroid, which may come by 2016, and it may stop 60% of surgery. Now, if you are seeing this morcellation, if you see, it's like a big egg with an egg yolk. So what happened is after some time, we couldn't morcellate only because now if you spill all this material in the abdomen, no amount of cleaning will work. That is, we call as earlier morcellation, I used to call it's a naked morcellation. So this bag protects the spillage. And this was so soft that we had to actually use an ovum forceps and pull the specimen out. So this is how it was removed. So now you can imagine how much spillage can take place if you are doing even laparoscopic myomectomy and you are removing the specimen with some other method. So this was one major advantage which I felt. Now, this is the degenerated fibroid which I showed you. This is another type of degeneration, wherein sometimes you have so much of fluid. So much, it is like a mucinous change. Fibroid itself has 13 different types, including stump. So when you have such cases, I started realizing I am not worried about sarcoma. I am not telling this. Of course, anybody, our journal will tell, how can anybody tell? We have done approximately 25,000 myomectomies and removal of fibroid uterus for 32 years. We had 3 cases of sarcoma. One was in a patient wherein we had done laparoscopic myomectomy. She had found Recklin-Nonsense disease. So she came with a fibroid and another tumor arising from psoas muscle, which was on the nerve. So we suggested that we'll do an open surgery. And I, of course, called the surgeon. And that tumor turned out to be sarcoma. Another one of a patient in our own area, her uterus was almost looking like hematometra. So I did hysteroscopy and it turned out to be the endometrial stromal sarcoma without anything, without any spread in the blood vessels or muscle. So the number of cases are so little, and as I'll go through the presentation, these are the 2 methods in which, if you are abroad, you will widen this. So here, this is widened. I will just take a little time because this is how we do it in India. A tonsil can be removed from vagina. That's the quality of Indian surgeon. So whether it is expert surgeon from India or expert person from Asia, anybody who is expert in vaginal, by coring method, I remember once in AGL, one of the Indian surgeon from South demonstrated 34 weeks laparoscopic hysterectomy, and he removed a specimen vaginally in a live AGL event. So what happens in India is you have the skill, and as you see this, all this tissue is spilling. You are removing vaginally, but everything is getting contaminated. So if there is anything, I am always more worried about leiomyomatosis, or we have even cases of walled fibroid. So these are different ways in which people will try and remove, which to many it is acceptable. I started thinking that if I can do from 14 May 2015 till date, me, my son, and many others, any undiagnosed specimen is always removed in contained bag. So we had a study which was published with 720 cases. We have a spread over 8 years. So we had cases after 2015 till now, almost all we are doing in contained bag fashion. Any undiagnosed specimen, because we don't believe that size, number, or anything can protect you. Because if you get one case, you will be sued, whether that case is leiomyomatosis or very, very rarely sarcoma. The second thing, oncology multi-institutional study in Vienna found that 71 cases of leiomyosarcoma were backdated, none were fibroid. Finally, in the current NOAC textbook, it says clearly that the genes causing leiomyosarcoma are totally opposite of fibroid. So fibroid cannot change into leiomyosarcoma. It's only because fibroid are so prevalent, rarely you can have a sarcoma. But if I'm telling you in our 55,000 surgery, we had 3 cases of sarcoma, and being a referral center of fibroid and large uterus, now obviously you're well trained in vaginal surgery. You know, if you are anybody in India, I think so you're always well trained in conventional surgery. And vaginal surgery is the most minimal access surgery. So basically, this clearly suggests why leiomyosarcoma is very rare, because the incidence is so rare that the genetic cause of fibroid is very common and very prevalent. Out of 100 female having a normal death, 33% can have fibroid. Of that, 40% have no symptoms. This was a case which I had done with in our IIG President's Hospital, and he is very unique. You know, he always will give me some difficult case. So on the same day in the morning, they had a fibroid which was opened, and he told me, okay, there is one interesting case for you. And he told it diagnosis is a variegated mass around the uterus. So when I started operating, the whole audience was in pin drop silence, because I started realizing that the tissue inside is all vascular. So all this, if I hold with a tenaculum or with something, then it can be dangerous. And obviously we didn't know what the diagnosis is. So she had one posteriorly and someone similar anteriorly. So this was a case of 29 case of angioleoma. When I went to the person that you give me the film, he told, what luck you bring. She was infertile for 14 years. And now she's pregnant, which was just 4 months later on her own. And she's gone to village. So he had the recording. Then I took it. Now this, when we put in a bag, nobody can say what this tumor is. But this turned out to be angiolipoma. So basically you have to remember, as you have more and more cases, you have more and more mental capacity to handle difficulties. And I always say that a surgical genius is not born in crisis. They are born to exhibit in crisis. And that was also the case in this situation. She didn't have much blood loss. She conceived spontaneously. She delivered subsequently at the same hospital. So our...
Prakash sir, I'm sorry to interrupt. We can keep seeing your videos. They are fabulous, but we have a very few minutes left. So if you could now move to your paper, actually, that would help. Yeah, okay. Thank you.
I have already moved to the paper only.
Perfect, perfect.
So our point was, we wanted to evaluate the safety of visual contained morcellation of fibroid and uterus. to evaluate the duration of surgery, blood loss, complication, histopathology, patient parameter during morcellation, to assess safety. All these bags were, after removing, filled with 1.5 liter of methylene blue to check if there was any leak or any puncture. So we had 426 cases of laparoscopic visual contained bag morcellation, that is after May, and 430 cases from 2011 to 2015. So we evaluated various parameters. There were many people following what we were doing, but we intentionally stuck to our data so that it remains more relevant. So all cases of laparoscopic myomectomy and hysterectomy required this essential step. Ethical institutional permission was taken. Pre-op preparation, sonography, color Doppler was in all. MRI was not done as a routine because it can be, I don't find that color Doppler is anyway inferior. And everybody cannot afford so now inclusion criteria is myomectomy wherein the patient wants to conserve the uterus. Uteruses which you would have removed vaginally by bisection, coring or cutting. So anything wherein you're going to cut through the tissue was an indication of contained bag morcellation. Patients are keen on minimal access surgery. You know, sometimes they call it as a laser surgery, but we have to explain that there is no laser surgery, it is laparoscopic surgery. No other risk, no high risk factor which disallowed laparoscopic surgery. Patients consented from start to end to follow the protocols what we have taken, and they were to follow up. So once this thing were done, then there were exclusion criteria wherein anything which can be easily removed vaginally, there was no point to remove. And our case only included myomas or hysterectomy with myoma. So any uterus which can be removed vaginally, there is no point in removing. Beyond 30 weeks and beyond 24 centimeter now, we find there is a limitation of how much you can do. The study group had two groups, myomectomy and hysterectomy. There were adequate number of cases, close to 46, 53, 57% in different group. So we had the control group also a sample size which was matching to our 426 cases which we had. Further, when we went ahead, this was the finding: average age, number of fibroid till 17. Now, in between, we removed 78 fibroid. But to be practical, it was a patient from some country in Arab. And we told that we will do it, but we were not foolish to remove all. We laparoscopic assisted myomectomy with Nizat introduced in 95. So we removed a specimen in that fashion. So sometimes doing a conversion in a suitable patient by open surgery is more sensible than trying to attempt too much. Weight varied to maximum we have now is 2386. Hemoglobin, average hemoglobin, intraoperative complications, post-operative complication. If you can see the number of post-operative complication, incidentally in all the groups were very low. In control group, but as well in the contained bag morcellation group. So now, in terms of surgery, it was very interesting to find that when we evaluated all the cases, the in-bag morcellation took lesser time. And one of the principal reasons was because you didn't have to go and search for the specimen, which was spread all over, which you have to do in any other form of morcellation, whether naked or also you have to give a wash. Blood loss was comparable. Complications were not a big issue. Post-operative, obviously, some issues were there, which I will highlight quickly. So this is myomectomy. In fact, in myomectomy group, the time taken was less. That is because even if you have 6, 7 fibroid, whatever it is, everything was in the bag. So you didn't have to hunt anything outside into the peritoneal cavity. Blood loss was comparable. Post-operative complication 1.5 or 1.7%, again comparable. Then in the hysterectomy group, one beautiful thing, Anahita, is very important. Hysterectomy is a closed specimen, unlike multiple fibroids. So hysterectomy, laparoscopic takes much lesser time because once you put the specimen inside, then you are morcellating. The average time earlier we used to have 17, 18 minutes because that period of time difficult cases were not coming. Now we have huge ones, but you save by in-bag, which takes 5 minutes or less, or insertion and specimen loading. Morcellation time is reduced because you don't have to search for tissues anywhere else. Conversion to conventional morcellation we had to do in two. In one which was open, in one we had wasted 4 morcellators because it was calcified fibroid. Eventually we had to almost remove like an orthopedic patient. Mortality is nil, no sarcoma, no malignancy. This is the data of 8 years, and we didn't exclude any patient. When we published, 2200 was the highest in number and 20 centimeter. In recently, we have almost 2.4 kg and 24 centimeter. So all this is, all these limitations are in the mind. Once you have achieved surgical excellence, you can, no case of leiomyosarcoma on all cases of 8 years. No evidence of residual or parasitic fibroid. Spread 6 months, we had imaging post surgery, and we could find minor complications were there. To conversion, as I told, there was some unacceptable. Anita, when my time is up, you tell me. Uncontrollable back.
It's fine, sir. Please go ahead because this is also extremely important and interesting.
No problem. Thank you, madam. So there was, sometimes what happens is if there is a specimen which it can have an axial rotation. So you're seeing that a fibroid is inside, but when you're looking through the laparoscope, you can't find the specimen. So in such cases, we had to change by untwisting, or there were inadvertent punctures. Inadvertent puncture because if you're using a tenaculum, you can puncture it. One conversion to open, as I told you, because it was a large calcified fibroid, we wasted 4 morcellators. Then I realized there is no problem. Then when we even removed by open, it was difficult. We had 2 port site wound infection. And one, surprisingly, we had right small port side hernia, which was, I had a very good assistant. They used to be very enthusiastic. So what happened that 5 centimeter actually became 1.5. And fortunately, we detected, saw laparoscopically, removed the bowels, and then took safety stitches. Duration, as I told you, duration, if you see, it is 104 minutes. And in the control group, it was blood loss. Again, if you see, it's comparable. Complication, as I told you, there was not much. Regardless of weight, size, and number of fibroid, we maintained that whichever morcellator we had, because what happened is, fortunately, we had 4 companies morcellators. So some of the important companies, I told you, if you're going to ban it, please provide 2, 3 more to me. Because at least in India, it is not banned. Our study had 856 cases of wherein comparison of visual and other open regular morcellation was compared, and it only added 1 step extra and benefit thousands of women who can benefit with minimal access surgery. I like few people. I remember our friend Hafiz and one more person. He told, no, I find the in-bag very difficult. So I told, just follow 5 cases whenever you are in Bombay. And there are many people who have picked up the technique, and now you will show it. So many places people are doing content bag morcellation. So most important thing is there is no current modalities available to diagnose leiomyosarcoma. All those things, LDH, this, that, etc., they doesn't really hold true. So basically our idea is when it is possible, you can do it. Current data I will not mention because we have now reached to 3,286. But sufficing it to say, okay, once we had to use double bag because the specimen was so big that we removed one and then we used the other one. And in one, as I told you, we had to convert to, there were 5 bags which were punctured accidentally. So lastly, to conclude, problems or difficulties are going to come. And we are here to envisage our journey in that with a leap of faith and some light and spark with innovative solution, like what our vaginal surgeon did for India, what many people do in obstetric, what many people do in urogynec and many other branches. Solutions to move past the problem and hurdle, then you start realizing that every problem was waiting for your solution and you can move ahead. So thank you very much for a patient hearing.
Congratulations, Dr. Prakash Trivedi. If we can have all the chairpersons and Dr. Trivedi.
Just put the gallery view.
Please put it in gallery view.
Sir, you have to stop sharing, I think, sir.
Yeah.
Prakash,
Okay.
sir.
I
So,
will do.
Dr. Prakash, brilliant paper. I think it's not possible for any other person to have 850 cases in such a short time. I just wanted to ask if you had to talk about any bias in your paper, what would the biases be?
Yeah, I think so. I always keep telling the biggest problem with endoscopies is ego. You know, their problem is look what I can do with my laparoscope. So I always, in fact, once I was discussing with Durusha and many others, I told, look what I'll do for my wife, for my sister, for my daughter-in-law, daughter, the same will use. Obviously, there was a little bias that we introduce a technique which can be popularly known as the Indian technique of contained bag morcellation. In fact, there is other modification the next generation is working. Some biases in any research will be there because if we don't do that, and for example, from 2015, if you are doing half in bag, half open, then the whole purpose is lost because, you know, nowadays anybody can sue you for any problem and people are waiting for that.
Right. So I think
Very right.
probably one of the inadvertent bias was that when you were doing in-bag morcellation, you were far more skilled at operating than probably in the earlier part of the.
Correct.
Otherwise, I don't think there was really any difference. So would you suggest that all fibroids should be in-bag morcellated?
See, my problem is we can map the fibroid with MRI. Nobody can guarantee and tell me that this will not be sarcoma. For being probably sarcoma, people will do open removal after separating laparoscopically. So I firmly believe that if you have a principle that you are doing for preventing leiomyomatosis, and of course a rare sarcoma, all cases we preferably do with the same bag and same. Very often, some cases are difficult. We voluntarily tell the patient that you are not suitable. A good open myomectomy is better for you. So we don't hesitate. So we don't become too egoistic because if any conversion is to be done, it is done in first 2 minutes only. Otherwise, the anesthetist is sure that this case will get over.
I think, sir, that's a very important point for the juniors because the juniors feel that anything and everything can be removed laparoscopically. So I think as you grow older, you also know your, what
you
is
cannot do.
the correct thing to do. Yeah. I don't think it's
First
what you
judgment.
cannot do because Dr. Prakash can do everything, but
Yeah, to have a point.
Yeah.
Sir, Prakash,
Sorry to
if I may-
disturb, ma'am. Dr. Alka Kriplani, madam, has joined and she wanted to make a comment.
Yeah.
Welcome, madam.
भाई मैं तो ओटी में स्टक थी, अभी अभी मैंने प्रकाश को देखा and I heard that Prakash can do anything, but I think it's a very I could see Anita, I could see Shobha, and I really agree with Prakash if he has said that one has to decide. If you are a good clinician, you are not only a laparoscopic surgeon or you are not only a cutter. So you have to decide. Secondly, I think Prakash must have mentioned in this lecture about in-bag morcellation. I would again reiterate, it is not only to prevent cancer, it is mostly to prevent leiomyomatosis also. And I operate so many patients every 2-3 months. They come with leiomyomatosis. It becomes such a ugly situation. So I think we should all morcellate in bag, and big surgeons keep criticizing that already damage has been done. All that is correct, but we should not further damage. And I strongly believe we should morcellate inside a bag so that, to take care of all those pieces who get spilled in the abdominal cavity. And I think morcellation becomes safer inside the bag.
Thank you,
So
ma'am.
thank you for the invite, but I got stuck in a very bad case, so I have just come out. I apologize, but then I could see my dear friend Prakash here, and he must have spoken on in-bag morcellation, and I could see Anita. Thank you for the invite, and this is research methodology, and you people are doing great work, and more and more youngsters should be involved in clinical research.
Alka
Yes,
madam,
sir.
I think so. We should say that we are blessed. You have heard my talk in so many places. So,
Yes,
so
Canadian.
many of the things are not new for you because I and Alka operate maybe 500 times we have operated together in workshops. So you coming in this forum is a big advantage to this whole group of absolutely meticulous people from JOGI, starting from the editor, assistant editor, whether then I remember those time even when Suvarna Khadilkar was there. But the process to get your thing acknowledged by Jogi was not an easy thing.
Right,
almost,
Abdul. I agree with you.
yeah,
Yeah.
and I
Yeah.
actually congratulate. I remember my great friend Shekhar Hegde, who was just 1 year senior to me. Then all the previous people, currently Anaita, and then the current chief editor Geeta Balsarkar, all these chairpersons and all.
Madhuri Patel.
Madhuri Patel.
Honestly, honestly, as I told in the beginning, I felt like I am sitting in an exam. and I was only worried कि भाई अनाइता बीच में कुछ बोलेगी तो मैं क्या जवाब देगा.
नहीं.
सर मेरा एक
No.
एक
Thank
छोटा
you,
सा
thank
डाउट
you,
है.
sir.
I have a very basic doubt regarding your paper. Of course, it has been a thrilling 1 hour of witnessing your great work, sir. We are so blessed that such a great surgeon has today come here, sir. I just wanted to know, did you face any ethical challenges, ethical approval, because already it was established by the time you took that in-bag morcellation?
That is
Yeah.
a very important question.
Yes, sir.
Because I went to Somaya Hospital Ethical Department, many ethical department, they all told that we can permit you if you are operating here. So I was at Rajawadi Hospital, but to be very honest and frank, sometimes the OT sisters don't want you to do laparoscopic surgery. So I was there, then my son also joined. Then suddenly the matron who never enters the OT. So from that day only, I decided that we will do it in our private practice rather than doing. So we have to now. I am very happy whether it is AM, whether it is Wadia. There are so many hospitals here, and many places are doing wonderful endoscopy work. And young people, as Anahita rightly pointed out, people have so much of madness to project every day anything. No, it is good. Yeah, my point is if you're projecting 10 different surgeons, it is a good idea you're educating. But what happens is it has become a fashion. In fact, because all these things I actually go, but I don't open. Because what happens is once you open, you may make a comment. And then if you make a comment, that is also a problem. I think so. I saw Sonawala sir.
Yeah.
I was remembering him.
So can we just ask that what ethics approval did you take before submitting?
So we went through a proper ethical committee, which is in Thane.
Okay.
We approved to that. And
I think that's important for us because when you are a private practitioner, you should go to an independent ethics committee and get their permission before submitting to any journal.
Anita, can I give one more advice?
Yes, ma'am.
Always get your whatever research topic you want to work CTRI registration. Otherwise, it becomes very difficult to publish that work. And so do these things beforehand, all youngsters who are sitting here. And it is not difficult to obtain ethical because nowadays they at AIMS also like private practitioners can apply to independent ethical committees. Government people may not always oblige because they say it is our hospital only. So go to independent ethical committees. Pharma people also help, and always get CTRI registration done and then publish.
Thank you, ma'am. That's a very valid point. And I think Dr. Sunawala is waiting in the wings to give his comments and his pearls of wisdom. Thank you very much, Prakash sir.
Thank you.
Over to you, Prajna.
So can we request Dr. Sonawala sir to comment?
Pragna, I would like to say something.
Yes, ma'am.
Yeah, I must first let me say hello to Madam Kriplani. That in spite of her busy schedule, she accepted our invitation and she could join and she could give a very good advice to everybody, over here. So we have to learn from our, experts about laparoscopic surgery. And Dr. Prakash, it was an excellent, talk. I will say your paper, but it was like an oration. So we really enjoyed everything and we learned many things. And I was worried whether Dr. Prakash will come for the presentation or not, because I was little worried, but I said, no, we should ask him.
Can I say something? When a person like Madhuri is there at the top, anybody will come running because everybody respects her so much.
I know, madam. I know you will definitely come, and Dr. Prakash and everybody will come. So nice of you, madam. But Dr. Prakash, I was really worried, when we invited you, whether you'll accept or not, because you have become such a senior person. But I said, no, let everybody learn how, because this is a discussion we take from authors. Okay, how they did, what they did. So it is a discussion, very meaningful discussion for everybody to learn.
In fact, it's an honor and we learn from you people. In fact, when I started, I felt I'm sitting in an exam. So even my wife and son was telling, you have given such talk so many times. Well, this is different brain trust. I think so we should have a word from Sonawala sir.
Yes.
Sir, by the way, you won the gold medal in the exam.
Height of humbleness, Prakash, proud of you.
Yes. I now request Sonawala sir to please speak a few words. Sir?
Yeah. No, the only advice that I can give is laparoscopy is an excellent tool that we gynecologists were the first to start, and the way it has grown in the last 75 years is amazing progress of different instruments, But it cannot be that every gynecologist will be able to do all laparoscopic procedures as well as an expert who has the ample experience. So what I would advise for the benefit of the patient, that if you have a problem case, call an expert with you to assist you. And I'm sure in India, most of the doctors are very good, very friendly, and they would positively like to come and help you do some problem cases. The second thing is the equipment. It's a very delicate equipment, needs to be well taken care of. And as Dr. Prakash said, that 4 morcellites got ruined because the fibroid was calcified. And that is one lesson to learn, that if you find the morcellate is not cutting, don't keep trying and go to the alternative of opening or whatever you like. The third thing is that with the laparoscopy, if there are multiple small fibroids, we are not able to remove all. After a year or two, these fibroids will grow and the patient will be very upset. In spite of surgery, the fibroids have come again. But these were the fibroids which were impossible to see deep in the myometrium, small in size, which gradually grow. So one could, from the beginning, tell the patient, it's that we remove whatever is seen and whatever is there, but we cannot guarantee in future other fibroids will not recur because they can come again. So that the patient is from the beginning. It's an excellent talk which Prakash gave. The credit is that he concentrated on endoscopy as his most favorite tool. And this is the result of the dedication and concentrating on one method more than all other methods. So these are the few things I would love to say. Thank you. Thank you for the patient listening.
Thank you, sir, for joining. I really appreciate Sunawala sir that he has taken a keen interest, joined here, and he has given his inputs to all of us, which is very valuable. So thank you, sir, for joining and giving us the honor for the same.
Thank you.
Okay, let us move ahead with the program. So I request chairperson to introduce next speaker.
Come on. Sorry. Just mute. Switch off your camera.
Just give me a second. The slide is stuck. 2 minutes. Please go ahead.
The other talk is by Dr. Nikita Kumari. The paper topic is Effect of a Locally Tailored Clinical Pathway Tool on VBAC, that is Vaginal Birth After Caesarean Outcomes in a Private Hospital in India.
Yes, Dr. Nikita Kumari is coming up with another debatable topic. It is the real topic to discuss, that is about VBAC. And she is presently consultant in the field of obstetrics and gynecology in Sitaram Bharatiya Institute of Science and Research, New Delhi. Areas of interest is high-risk pregnancy, infertility, and endoscopy. Paper and poster presentations, she has done many. One is oral versus intramuscular vitamin D in peri and postmenopausal women at 57th AICOG 2014 Patna. She is very young gynecologist, and poster presented on menopausal symptoms, then paper presented on psychological and somatic effects. There are many poster presentations, but she is very young, energetic, budding gynecologist, attended a lot of quiz competitions and already made more than 7 public publications. She is winner of best paper in many FOGSI forum. So this is the right platform for you, Dr. Nikita, to present yourself. After Prakash Trivedi's talk, really you have to take the challenge to make it interesting. Yeah, you are most welcome, Nikita.
Yes, sir. Thank you so much, sir. Thank you for this warm welcome. And I understand after sir's presentation, it will be a challenge for me.
But Nikita, if I may say so, your
Yes,
subject has a very, very high relevance in today's obstetric practice.
Right,
Because
ma'am.
because the incidence of cesarean sections are so high, and we are all looking towards solutions. And one huge cohort is women who have had a primary cesarean section and have come back for their second birth. So I think it will be absolutely, worthwhile listening to you. Please go ahead. Yeah.
Yes, ma'am. So my paper is basically a journey of VBAC, and this journey would not be complete without the people who were there during my this journey of VBAC. I would have loved if my co-author, Dr. Rinku, would have been there, but because of some prior commitment, she could not be there. I have with me Dr. Anita Sabarwal, ma'am. She is a senior consultant at the Sitaram Bharti Institute, and she has more than 24 years of experience, and she has strong interest in general and high risk obstetrics, and she has been a key practitioner in our group practice model. So I'll begin my presentation. So the topic is effect of a locally tailored clinical pathway tool on VBAC outcomes in a private hospital in India. So the international guidelines, the Royal College, the American College, and the Canadian College all have indicated that attempting VBAC is a safe and appropriate choice for most women. But as ma'am said, we are seeing that there is declining trends of trial of vaginal delivery after a previous cesarean. The VBAC rate varies significantly from one country to another, from almost 10% to 50%. In European countries like Finland, Sweden, and Netherlands, the VBAC rates are quite high, till 50%, whereas in United States and Australia, the rates as low as 12%. We also tried to study two studies from India. There was a study in 2018 in a tertiary care hospital in Madhya Pradesh. There are 36% women with previous cesarean who attempted labor. They had vaginal birth. There was another study that is ICMR task force study that was done for a period of 8 months in 2005 and 6 at 30 medical colleges and teaching hospitals in India, which indicated that the overall VBAC rate was very low, 16%, although the success rate of vaginal birth who attempted TOLAC was 62%. Hence, the debate of VBAC versus elective repeat cesarean section is very relevant as the nation is witnessing steeply rising primary cesarean rate. What is the most common fear in the minds when somebody thinks of VBAC? The most common deterrent is fear of rupture uterus. The risk of rupture is 0.5%, 1 in 200, and it is comparable to other acute obstetrical events like cord prolapse and abruption. Among the caregivers and also among the patients, there is a perception that the risk of rupture is unacceptably high, and therefore the culture of care shifts towards a repeat cesarean section. The patients are therefore not able to make objective assessment of the risks involved, and they feel that the repeat cesarean is the best option. Some of them even undergo cesarean before 39 weeks to avoid labor, which increases the perinatal morbidity due to respiratory complications. Also, having repeat cesarean sections increases the risk of placenta accreta, which predisposes the mother to life-threatening hemorrhage. So there are important determinants of VBAC outcome. One is inconsistent antenatal counseling. Even the healthcare providers are hesitant to recommend VBAC due to perceived risks and also maybe the lack of expertise. Solo practice care leads to insecurity among the care providers. There are litigation pressures in the private sector, and the care providers feel there could be some legal repercussions if there is some complication during TOLAC. And in the public sector, lack of manpower associated with overcrowded facilities is one of the important determinants. So we analyzed our data way back in 2013, and we realized that our overall cesarean rate was also high, 39%, and the VBAC rate was very low, 19%. So because of that, we tried to introduce a standardized clinical care pathway tool in our hospital in the year 2016, with the aim of improving the VBAC outcomes. I would like to talk about the hospital. The hospital is a 70-bedded tertiary care private hospital, which gives around 700 annual births, and approximately 15% of the women belong to Robson Group 5. In our study population, we took women with one previous cesarean, with cephalic presentation, and who delivered after 37 weeks of gestation. And the women who were excluded were the women with 2 or more than 2 previous cesarean, a person with previous known classical cesarean section, people, the women with multiple gestation, malpresentation, and previous cesarean with placenta previa. So the perinatal outcome was evaluated in 2 phases. The clinical care pathway was introduced in 2016. So the first phase was before that, from the year 2013 to 2015, and the phase 2 after initiation and introduction of the clinical care pathway. The study was done from 2016 to 2018. In phase 1, the eligibility criteria for TOLAC included maternal choice and an delivery interval of at least 2 years. The care providers were practicing solo, and therefore there was variable compliance to promoting VBAC. Not all women attended the antenatal workshops, and whoever declined TOLAC, they were not offered the option of a second opinion. An elective cesarean, when desired by maternal choice, it was planned at an earlier gestation at 38 weeks. And if any of these women presented in labor, no further counseling was done for TOLAC, and they went ahead with a repeat cesarean section. In phase 2, all the eligible mothers were subjected to this clinical care pathway, and this pathway was made utilizing international guidelines and OptiBirth project. I would like to tell something about the OptiBirth project. So this was a project which was done in 2012 to 2016 in 15 maternity units, where the VBAC rates were less than 35% in 3 countries, Germany, Ireland, and Italy. And they tried to investigate the effects of a women-centered intervention to increase the VBAC rates. But the interventions involved were only in the antenatal period. They mainly focused on evidence-based education for the clinicians and the women. So for the women, there were 2 sessions of 2 hours each, and for the clinician, there was 1 session of 1 hour. Audit and peer reviews were done, and joint discussion by women and clinician was done. However, this project did not yield much result, which suggested that only antenatal interventions are not enough to achieve a good VBAC rate. What is a clinical care pathway? It's basically a tool for achieving coordinated care and desired outcomes within an anticipated time frame by utilizing the appropriate resources. It is a blueprint that guides the clinicians, and it maps the whole journey of a patient. This is not something which is very new. It has been popular in other areas like critical care, ICU, surgery, orthopedics as well before. Why we needed a clinical pathway? As we were analyzing the data for the year 2013, 14, 15, we realized that by standardizing protocols and audit processes, we were making a significant difference to our primary cesarean section rate, but it was not impacting the VBAC rate. When the senior providers were asked, they discussed about their insecurity because they were practicing solo, and therefore they had insecurity about safety of care for the mother in emergency hours. Another challenge that was there was that there was a high number of patients who were opting for pre-labor cesarean section. That's why we tried to overcome our local barriers and then formulated a clinical pathway. So there was a similar study which was done at St. George Hospital, Sydney in 2015. They found that VBAC rates really improved. They adopted 2 management strategies and involved 3 senior consultants. So they allocated responsibility for VBAC candidates to the hospital's 3 high-risk obstetric consultants. And they also implemented a separate clinic, antenatal clinic for a previous section mother, which they named as Next Birth After Cesarean Antenatal Clinic. And the results were quite good in their study. So there were some important points in our care pathway. One, as we understand that having TOLAC, intensive intrapartum surveillance is very important, and it is the backbone for ensuring safety for the mother as well as the baby. So our hospital, in fact, with the help of the stakeholders and the owners, they tried to help us and fund us for learning the CTG courses. Not only the doctors, the nurses in the labor room were also made to attend the K2 training, perinatal training programs, which strengthened their knowledge in CTG, because we understand that in a case of TOLAC, abnormal CTG is the first and it is the most common. Almost 50% cases, it may suggest scar rupture or scar dehiscence. One very important transition in our care pathway was transition from solo practice to group practice among the same senior providers. So in our hospital, there are 2 tier of consultants. One is 5 senior consultants and 5 attending consultants. So the change from solo to group practice increased the reliability of care, and it instilled confidence of safety within the team. Also, one-to-one labor support and care by a senior nurse was instilled, and this provided immense confidence to the mother. But it also meant logistic issues like a flexible roster for the nurses, which they readily agreed to. Trying for a TOLAC, there could be an emergency situation anytime. That's why the anesthesia team and the neonatologists, they were apprised and sensitized regarding the urgency of an emergency cesarean in a woman undergoing VBAC. So this is basically our clinical care pathway, which has been framed in one table. So we did some antenatal interventions and some intrapartum interventions. In the antenatal period, as discussed, one of the 5 senior providers, they were given the responsibility of optimally selecting the VBAC candidates. So they had to go through the previous discharge summary records of the patient to understand why the cesarean was done, and the VBAC checklist needs to be completed. All those patients were made to attend VBAC workshops in the presence of one of these senior providers. If at all some patients missed the workshops, then individualized session was arranged for them. VBAC information leaflets were provided to the patients, which very well explained the benefits and the risks involved in a layman language. Special focus was given on physiotherapy and diet session in each trimester so that the patient remains fit and they do not gain excessively weight during their pregnancy course. The women who did not labor till 39 weeks, they were offered sweeping of cervix twice, once at 39 weeks and once at 40 weeks. If there was no other risk factor to the mother and the baby, then the mother were allowed to labor till 40 weeks and 6 days. If by that time also they did not go into spontaneous labor, their bishops were assessed. If the bishops was unfavorable, they were offered cesarean section. If the bishops was favorable, selective induction was offered to them. Group practice I have already discussed before. In the intrapartum period, uniform protocol for labor management was followed. Partner support was encouraged. The partner was also apprised regarding how the VBAC journey will be, how the labor process will be. The senior consultants used to stay within the premises if any high-risk patient, including a VBAC patient, was there in the labor ward, so that anytime if surgery, cesarean is required, they are present there. Senior nurse with one-to-one care and continuous CTG in active labor was there. As mentioned, continuous OT and anesthesia availability was ensured. Women who were already planned for elective repeat cesarean section were re-counseled for TOLAC if they came in labor. So this was our clinical care pathway. The outcome for our study was measured in 2 forms, the primary outcome measures and the secondary outcome measures, and both were compared in the phase 1 and phase 2. The primary outcome measure was VBAC attempt rate, that is the proportion of eligible women who opted for TOLAC. Second primary outcome measure is VBAC rate, that is the VBAC birth among all women with one previous section in our study. Third is VBAC success rate, that is success rate of vaginal birth among women who opted for TOLAC. The secondary outcomes measures were the women who would spontaneously labor, who would be induced, proportion of women opting for repeat cesarean section, number of instrumental deliveries, and perinatal outcomes. If we look at the demographic characteristic and distribution in both the phases, in the 3 years, we had in the phase 1, there were about 1,600 births total. In phase 2, there were 2,000 births. And the number of population in our study was quite comparable, 13% in phase 1 and 11% in phase 2. If we look at the age distribution of women, the age of women in both phases were comparable, and the majority of the women belong to the age group 30 to 34 and beyond. And these days, we are even seeing more shift towards the age group more than 35 years, more than 40 years. This is the same flow chart depicting the data. Now coming to the distribution of women according to Robson classification 5A, 5B, 5C. 5A is the number of women who labored spontaneously. So there was marked increase in the number of women who would labor spontaneously in the second phase, almost 44% as compared to 25% in phase 1. This could be explained by the fact that more women were allowed to labor beyond 38 and 39 weeks and maybe till 41 weeks also if they had no other comorbidities. And as increasing gestation, with increasing gestation, the chances of going into labor also increases. Because of selective inductions and carefully choosing the right candidate for induction, the induction rate also increased to 19% as compared to 11%. And there was marked reduction in the number of women undergoing elective repeat cesarean section. It was only 35% in phase 2 as compared to 63% in phase 1. Again, if we see the comparison of period of gestation for elective repeat cesarean section, it is well evident from the table that more women were chosen for repeat cesarean section at 39 weeks and beyond in phase 2. Coming to the primary outcome measures, the first primary outcome measure is VBAC attempt rate. So as said, the VBAC attempt rate increased to 64% from 36% in phase 1. If we see the VBAC rate, then the overall VBAC rate doubled, in fact 58% as compared to only 23% in phase 1. And the VBAC success rate, the women who underwent trial of labor in phase 2, 90% of the women had a successful vaginal delivery in phase 2 as compared to only 64% in phase 1. If you see the secondary outcome measures, again in phase 1 and phase 2, we had instrumental deliveries as well. And the number of instrumental deliveries increased in phase 2. And the number of emergency cesarean section reduced markedly in phase 2. It was only around 10% as compared to 35% in phase 1. Oxytocin for usage in spontaneous labor was almost similar in both the phases. I'll come to the maternal complications and the perinatal outcome in the subsequent slides. In our study period of 3 years, pre-clinical pathway time and post-clinical pathway time, there was no maternal mortality, and scar dehiscence and rupture was rare. In phase 1, there was a patient who presented in spontaneous labor, and she had an emergency cesarean for scar tenderness, and a 1 centimeter area of scar dehiscence was noted in midline of lower uterine segment, and the baby was born in good condition and did not need any further interventions. In phase 2, there were 2 cases of scar dehiscence. One of the patient presented with PROM with fever. Later fever settled and she was offered induction, but she refused. So she underwent emergency cesarean section, which inadvertently revealed scar dehiscence, but the baby did well. In the other case, it was a vaginal delivery. In second stage, acute fetal bradycardia was noted, and then the baby was delivered by a forceps. The baby was born with an Apgar of 4, 7, and 9 and needed initial resuscitation in the form of bag and mask. However, the baby was fine later on. The patient had postpartum hemorrhage, and then ultrasound was done for suspected scar dehiscence, which showed that only serosal layer of the uterus was intact. But the patient continued to have normal vitals and she was managed conservatively, and no further intervention was required in her case. Coming to rupture, the most problematic deterrent in VBAC. So in phase 1, there were 2 cases of uterine rupture. One was a very rare posterior wall rupture. The patient had to undergo emergency cesarean for an abnormal CTG, but hemostasis was not being achieved. So carefully, the posterior wall of the uterus was checked and there was a rupture there and it was sutured. The baby was born fine. The second case of uterine rupture happened a woman who came in spontaneous labor. She underwent epidural analgesia, but then there was abnormal CTG for which immediate cesarean section was done, but there was a left lateral wall of uterus rupture was noted. The baby was born hypoxic and it led to early neonatal death. So this was the only neonatal death which happened in our time. In phase 2, there was 1 case of uterine rupture, a patient who presented in spontaneous labor. She underwent cesarean section in view of pathological CTG and scar rupture was noted. The baby was born with an Apgar of 3, 7, and 9, but immediately responded to resuscitation. So we understand that a very high index of suspicion and constant continuous vigilance over the CTG and the fetal heart rate is a prerequisite for TOLAC. Good maternal and fetal outcomes are achievable, and with prompt coordination with the team response and swift recourse to cesarean section, in the rare case of uterine rupture, good maternal and fetal outcomes are achievable, and very bad perinatal morbidity and mortality can be avoided. Bladder injury were seen in 2 patients. Incidence of PPH was significantly increased in phase 2. In phase 1, we used to take the records from the individual case notes from where the assessment of the PPH was as per the individual care provider. So when we started our care pathway in the year 2016, we modified our labor and delivery record sheet, and specific columns regarding PPH was added for blood loss during delivery. So possibly all cases of PPH, even including the minor PPH, were documented accurately. That's why the incidence could be more in our phase 2. And 2 women in each phase required blood transfusion due to major PPH, and none of them required surgical intervention. So this indicates a comparable morbidity due to PPH in both the phases 1 and 2. Talking about oxytocin, as mentioned before, around 40% women in spontaneous labor in each phase required oxytocin for augmentation of labor. As per the data, there is a 2-fold to 3-fold increased risk of uterine rupture with oxytocin induction and augmentation. And we know that the use of oxytocin as part of our VBAC policy may have the potential of serious morbidity. However, if oxytocin use was to be abundant, then the VBAC success rates in our case are likely to be reduced. That's why careful usage of oxytocin and continuous interpretation of the baby's heartbeat and the mother's well-being is very important. And this raises the inevitable question of balance between whether the cost of lowering elective repeat cesarean by increasing the VBAC rates is too great or not. So I would like to conclude with a few slides that there was a population survey in Delhi in the year 2014-15, which showed that previous cesarean as a sole indicator contributed to about 15% of total cesarean sections. And this continues to increase in parallel with the rapid rise of primary cesarean. So there is an utmost need to offer VBAC to appropriate women and create a process designed to support care providers for maximizing success. Choosing a mother who has the maximum chance of VBAC is very important, because the perinatal morbidity and mortality in case of a failed VBAC is much more as compared to an elective repeat cesarean section. Coming to the limitations of our study, from our study, it is not clear whether which particular study in the VBAC pathway had more impact than the other. We had 5 senior obstetricians who were willing to provide a 24-hour on-call and all-floor service, which may not be generalizable to other clinical settings. Also, this study was performed only in a single center. We did not randomize the sample size, and the sample size was modest. And of course, the management strategies were not independently studied. But the strength of this study is that this is one of the few studies on process improvement for VBAC outcome in a private sector, and private sector caters to a considerable fraction of maternity care in Delhi. The Our Clinical Pathway tool showed improvement in outcome with the same senior providers in the same clinical setting. So this emphasizes the need of systemic changes in all institutions, but we understand that the application of this pathway may not be universally feasible to each and every setup. At the end, I would thank everyone for the patient listening and conclude by saying that VBAC can be a safe option for many women, especially when appropriate precautions are taken, and an informed decision should be made based on individual circumstances. Thank you.
Very well presented, Dr. Nikita. I request respected chairpersons for their comments as well as question answer session.
Shobha, would you like to go ahead?
Yeah, I think I must first congratulate the hospital and the team for stepping up and trying at least to put a different perspective on management of previous single known uterine scar. That was your patient cohort. it is excellent that you have brought in the system preparedness for management of such high-risk deliveries. So I could see that you have brought in the entire system, and it is not only one obstetrician who has taken the decision and is kind of, responsible for everything. The entire system is geared up to give the mother a vaginal birth. It's very good. One thing which I felt amiss was that the phase 2 part was consistent more or less with the labor care guideline. So if we utilize a validated tool like an LCG, probably the data which you get will become comparable to other such studies. So that is one thing which I found, that your assessment tools were highly individualized. And therefore, that is what you also had a doubt, that, whether this will be accepted as a validated tool. So if we, going forward, if we adapt to one of the established tools, then the data becomes comparable. That is one thing. The second thing, in the finer aspects of the study, I think I was not very clear about the decision to delivery interval, which kind of, which is the most important factor which gives courage for VBAC in an institution. Because many of us want to give VBAC, but we feel that, by the time the anesthetist comes and the baby is taken out in case of a problem, that is a potentially litigious area. So the decision to delivery interval is what I was not able to make out. Suppose there is an emergency cesarean. So what I was looking for was an analysis of the emergency cesareans which have resulted in your study, which have kind of happened in your study, and how safe it was for the mother and baby. But otherwise, I think it was great, very great attempt. And I really compliment you for that. Anahita, it is yours. Yeah, of course, Nikita, if you want to respond.
Yes, ma'am. Thank you so much, ma'am, for your comments. So your first comment was regarding the WHO Labor Care Guide. So since I'm here and as I got to know from my seniors as well, so we have not been using any partogram in our hospital. We follow a different customized labor and delivery template. So from the last 15 days, in fact, we have started utilizing the WHO Labor Care Guide, because it will be a very important tool even to reduce, first of all, the primary cesarean rate, and of course, it will be applicable to the VBAC rates as well. Regarding the decision to delivery interval, ma'am, so we have our crash cesarean protocols in place. So whenever there is a crash cesarean, we have a flow chart which is there. So there is a crash cesarean buzzer which is pressed, and the patient is shifted to the OT within next 5 to 7 minutes. And we have on-floor anesthetists and pediatrician and neonatologists available. That's why we are able to do such kind of VBAC and high-risk deliveries. And all have been like a gradual change, because system changes took time. So all the changes have been streamlined gradually, and now the things are in place.
Thank you, Nikita. I think it was really interesting to see what can be done when a group of people has the power to change. Dr. Sabharwal would like to add anything, because she was, I believe, the senior in the group. So in case you want to add anything. Ma'am, you're muted.
Ma'am, please unmute yourself.
Yeah. Yeah. I just like to say one thing, that because I've been part of this journey, and I think what made it successful was that we all teamed up as a group, and we all realized that unless we form a group of doctors with the same vision, we'll never be able to reach, be it for the primary or for the VBAC. And then we sat down and created this system, because like all of us are concerned for the safety of the mother, and for the excellent comment about the fact from the decision to delivery interval. Yes, it didn't come up in this presentation, like you said, because for us, we assume that we have a very great protocol of crash cesarean, which we've refined over the years. Even now we are refining it. So possibly that is one thing we can look into the data as to how many women later on. I mean, now when we have cesarean, as to the decision to the the minutes that go by the time the baby is out. That's important. Besides, the journey has been with its ups and downs. I mean, I'm not averse to saying that we cannot sometimes sustain this level of VBAC rates, because you have changes in the team, you have changes in the nursing team, you have changes mostly positive towards the infrastructure, but then sometimes there are changes in the interdepartment association, so there are these ups and downs, but we try to maintain what we started. And with the younger consultants joining us like Nikita, I think we'll do great in future also. We have a vision, we try to follow it.
So I have one question.
Yeah.
How often do you think the team should be reminded or trained about these protocols?
Crash cesarean, Nikita, we have
Not
every
crash
quarter.
cesarean,
Not
the
only about the
entire
crash, VBAC.
not the crash, about the entire system which you have instituted. How often do you think the nursing staff and others need to be trained?
Ma'am, there
And
is
do
no
you
particular.
think?
Yeah.
Yeah.
Yes, please, ma'am, please continue.
No, so I, as a secondary question, is it possible to, mimic this in a public setup?
I think it's tough because the absolute number of patients, and then the variety of patients that they have, and the actually they deal with higher risks also. Higher risk patients like I mean, they would have patients who are in obstructed labor more. So they have a variety of patients wherein the care provision for a VBAC or trial of labor to provide for them is going to be difficult. Constraints of managing manpower, because logistics issues are there. One-to-one care, sometimes even our setup also, we tend to miss. It's not always 100%, because even our staff could be sick sometime, and having a buffering staff. So for a public sector, it would be difficult, I think, unless one particular unit takes it as their goal, their mission. The idea for them is to prevent the primary cesarean. I think that is where
I
to
think
work
that
on.
makes a lot of difference.
That is very important. I have two more inputs and whatever we say queries. See, one is that a very, very important foolproof consent should be available, which should a consent form to follow, which should be kind of whenever we offer them VBAC to a suitable candidate TOLAC during pregnancy, and the thing should be revisited during labor, and again the consent should be reinforced. That is one aspect. And what did you have in your armamentarium? The second thing was the follow-up of that certain patient of PPH, where you said that there was a rent seen on ultrasound, but there was no long-term consequence. I feel that patient would have probably developed a symptomatic isthmocele later on, but not at that time. So a follow-up will benefit the mother. Not that kind of has anything to say against TOLAC, but yes, it is. Yeah.
Yes,
So
I guess, yes.
consent is
I think I think she was a very early mother. I remember, because I was the care provider at the time, and I had called in my own colleague, because I had felt that there probably was a rent, and on ultrasound, and since she was asymptomatic and everything went well, she did come back for follow-up for 2 years for other reasons. But yes, maybe we can reach out to her, because we have her data. No, that's true. We may reach out to her and find out maybe she's having a symptom which we don't understand yet. That is a valid point, ma'am.
The
I will
consent
make
is
it a
a
point.
very, very important thing which needs to be kind of
Consent.
discussed.
Definitely, yes.
Yeah, very good presentation by Dr. Nikita. Dr. Anita, you just made excellent center, and you are following, because I know Dr. Anita raised the question, is it possible in public sector? Rather, it is very difficult to do it in private sector. What you have shown your courage to implement, because everyone is answerable here more, rather than in a public sector where the people are coming and nobody knows who is taking care of who is patient. So you have really, I must congratulate you. You have really have the courage to institute such a protocol, and if it is implemented, in the private, in the public sector, by the government level, just making another emergency unit for midwifery, emergency unit for delivery, then it is possible. Everywhere in the bigger institutions, what I feel after so many years, even being head of the institute, even in PGI Chandigarh, that making every unit responsible for that, it won't serve the purpose. If you want to do this type of trial of VBAC and anything, you should have a separate unit for emergency and a separate team, dedicated team, taking the younger generation. That will be more fruitful.
Correct.
Absolutely.
Yes, sir.
Dr. Prakash Trivedi, your comments, please.
No, I was just listening because, fortunately, the next generation at our place and many places, they are very interested in high-risk obstetrics. And so I feel relieved because when I used to have 35 deliveries a month, then I started realizing that if you want to focus on something, you cannot have more than 15 delivery under you in a month.
Absolutely.
Otherwise, you cannot do
Absolutely.
endoscopy, urogynec, etc., etc.
Yeah.
Fortunately, the next generation are so well trained and interested. The next generation, if they're interested in obstetrics, I think so it's a big plus point. So a lot of people want to say, I want to do only IVF, I want to do only this, I would only do hysteroscopy. So I think it's a big error. Thank you.
Great point.
Excellent, Doctor. Yes. Yes, sir. Prakash, sir.
Thank you.
No, Dr. Prakash, ma'am. Yeah, just only one comment. Dr. Prakash, you are worshipped in Kolkata, in Bengal, do you know, as God of Mercilation. After that 35-inch your strip, then everyone, even who practices in the corner, in the remote corner of Bengal, they always remember you at the time of surgery. So you are now designed as God of Mercilation. Okay.
Can I make a comment, please?
Yes, yes.
I don't think, Nikita, that the term crash cesarean is a very common term, or that it should be started to be used, because we use crash intubation or crash resuscitation. So maybe we have to find a better word.
Right, ma'am.
Because I think what I think Shobha was saying of decision to delivery interval, this has been very standardized by the RCOG, and decision to delivery in the RCOG has certain classes, 1, 2, 3, 4, where 1 is emergency, very severe emergency, etc. So maybe we should restrict to that terminology rather than using crash cesarean. I know that all the newcomers like to keep using different terminologies, but
I think we should use that category. Anahita, you're right. Yeah.
I just want that comment to make.
Sunita, Sunil wants to say something.
In the chat section, one of our delegates, Dr. Preeti Dhamji, she is asking to put some light on mandatory training that staff underwent.
Dr. Preeti is again one of the senior consultants along with Dr. Anita. So as I mentioned in my presentation as well, so our staff, right from the nurses and the doctors, they underwent the perinatal training program. And that was organized by the institute itself, and they had to undergo the mandatory training regarding the CTGs and all the maternal like shoulder dystocia, PPH, and maternal collapse, everything. And they had to get themselves certified. And this training is done every 2 years for us.
Yeah, I have some input to give, Nikita, here.
Yes,
it is very good that your team is getting trained by periodic intervals. But I think most institutions which conduct emergency care work, obstetric emergency care, others, BLS, ACLS, everything, the training is not valid, I think, beyond 1 year for ACLS and BLS. But for obstetrics, there is a reason to conduct it every 6 months. There is a reason. And the reason which we found was, for example, we would like to show the basic steps of managing PPH to all our nurses every 6 months, because they will have lot of shift of duty.
Yes,
You know, and paramedics are not medically trained. They have a different skill set and a different mindset and different abilities for grasping. So they require reinforcement every 6 months. And incidentally, it is good for the junior and senior consultants and the postgraduates in the department also to go through, you know, some emergency obstetric drills. So drills is actually a very good concept for readiness, system readiness, you know.
Yes,
Even in
ma'am.
the government today, when they talk about Lakshya, they talk about the mandatory training. They say it is respectful maternity care and complication readiness, they call it. They call it CR. So complication readiness. So that is something every 6 months is going to be of high value, I feel, especially for the paramedics. Especially for the
Yeah,
paramedics. Yeah.
absolutely, Shobha.
Right.
Yes, Sunil, go ahead with the next question.
Yeah. So just an input from me. So rather, this is a very important topic, especially for postgraduates. And what you have done and achieved at private center is a motivation for all of us. There are various models. FLAM model is there, or Grobman prediction score is there. All this like that, we can very well generate, refine your system, and generate our own protocol system where FOGSI seniors can help us putting into FOGSI guidelines and having a mainstream practice. So such topics are encouraged to present and have multicentric studies. Thank you.
Absolutely.
Thank you.
Dr. Biswas, if you have anything to add.
No, absolutely okay, ma'am. Already all the points you have
I have to
discussed.
congratulate Dr. Nikita and Dr. Anita for taking such a bold decision in a private sector. And they could show us that they have really reduced the incident. They have rationalized the cesarean section rate. And, you know, it is encouraging to other private sector also to have such type of, you know, model where we can definitely give a feedback to our patient. And I would also like to say that there is such a huge cry over that increase in cesarean section rate, but we are talking about the rationalization of the cesarean section. If we are not, because the WHO also has said in 2018 that you should provide all this cesarean section to mother in need. So we have to remember that, but the VBAC is definitely going to rationalize the cesarean section rate. So I once again congratulate, and the group practice. I was going through the group practice really helps in, you know, all the feedback and the rationalization of the cesarean section rate. So I once again congratulate to all of you, and I thank Dr. Shobha, Dr. Anita, and Dr. Subhash and my team, Dr. Both the Supe, Sunil, and of course Maria, the person behind, every time she's after us to get the work done. So I'm really thankful to all of you. And please, we will have a good topic next time, and we'll come back to you. So vote of thanks, one of you can give.
We have come at the end of the session well within time. Dr. Supe,
Sunil,
madam,
I can just, Sunil, let me just thank Madhuri because I have not been able to do that. Thank you, Madhuri, for including me here. And because of your inclusion, I could listen to Sir's lecture. So mind-boggling. What a fantastic work he has shared with us today. And equally stimulating work by Dr. Nikita and her team. Thank you very much, Madhuri, indeed. Thanks.
Thanks, Dr. Madhuri, for initiating
Prakash sir,
such a
thank
program.
you very much. Thank you very much.
Our pleasure, madam.
One of you say vote of thanks now.
Dr. Supe, please go ahead with vote of thanks. Thank you.
Yeah, thank you, madam. So first of all, I would like to thank our EIC, Dr. Madhuri Patel, for providing such a lovely platform. I think both the topics today were such enlightening topics for anybody who's just starting out in their practice. So thank you, madam. I would like to thank our guest of honor and chief guest, Dr. Jaideep Tang sir, Dr. Alka Kriplani ma'am, and Dr. Rishma Pai for honoring us with their presence. Our chairpersons for today, Dr. Anahita Chauhan madam, Dr. Bishwas, and Dr. Shobha Gudi madam. Thank you for your expert comments and questions. Our two most important speakers for today, Dr. Prakash Trivedi, sir. Sir, it was an honor seeing your videos and hearing you talk. And I think everybody who has attended today's webinar has benefited by seeing them and understanding better about the benefits of morcellation. And Dr. Nikita as well. I think it was a wonderful study. I mean, VBAC can be prioritized so much and given so much attention. I think it was really nice. Most important thanks to our MOCs for today, Dr. Pradnya Changede for coordinating everything, Dr. Sunil Tamwadekar, our Assistant Secretary, our webinar. Thank you so much. And Vedika, who has helped coordinate the webinar today. So thank you so much. Thank you everyone for attending and looking forward to seeing all of you for episode 6 conducted next month. Thank you so much.
Thank you. Thank you. Thank you all.
So thank you everyone, and special thanks to Maria for really
Thank you.
coordinating
Thank you so much,
everything.
everyone.
Yes.
And Dr.
Thank you so
Supriya
much.
herself,
Yeah.
Dr. Supriya herself,
Thank
she is
you.
our assistant, she is our secretary. Thank you, everyone.
Yeah, thank you, everyone.
Thank you.
I'm ending the
Thank
meeting.
you, Sunil.
Thanks.
Thanks a lot.
Madam, thank you.